All right, welcome to Lifespan Considerations. We are going to do this as a self-study module, but I am also going to lecture on this so that I can help point out the things that are most important to you. So this is chapter 3, and we're going to talk about lifespan considerations. And when we talk about lifespan considerations, we're going to talk primarily about the two ends of the spectrum. So we're going to talk about kiddos, pediatric patients, as well as the elderly population, both of which you will get to have some experience and encounters with while you are here in your nursing program. So let's start with kids. Classification of children according to age. This is just a general breakdown for you as far as understanding the age differences between each classification. So you've got preemies, you've got full-term infants, neonates, infants, children, and adolescents. And what we do need to be careful of is that when we are taking care of patients who are in these different ages, that we do need to at least have a general understanding of how their bodies are a little bit different. And one of the biggest issues that I run into in my practice is if we have some 14, 16-year-old patients who come in to be treated in an adult environment, that they do require some different treatment sometimes, and we can't just, based on their size, assume that they are just like an adult. Okay, drug therapy during pregnancy is also important. We also always need to remember that drugs do cross the placenta by diffusion, and things that will affect the safety to the mother and the baby would include the properties of the drug, the gestational age of the fetus, so and then maternal factors. The FDA has implemented pregnancy-safe categories, and we should be aware at least of that and have conversations with our pharmacists while we're in the hospital if certain medications have been delivered, or ordered. Sorry, wrong way. Okay, and then it is pregnancy A through D, and then category X. Category X includes drugs where fetal abnormalities have been reported, and we absolutely would not do this. But category A is safe. Category B, you can see as you go through, no risk to the animal fetus, but we don't really know about humans because who's going to test on humans? Okay, so we just need to be aware and what we're giving our patients if we do know that they're pregnant, and we need to consult with our resources otherwise. Drug therapy during breastfeeding is another issue. Breastfed infants are at risk for exposure to drugs consumed by the mother, okay? And we need to consider the risk to benefit ratio. What kind of medication is it? What is it needed for? What would be the consequences? What's the risk ratio? Things like that, okay? So always thinking about risk to benefit ratio. Okay, neonatal and pediatric considerations. We need to think about pharmacokinetics. With these patient populations, we need to think about absorption. In these kiddos, the gastric pH is less acidic. Okay, so that can impact the absorption of a medication, especially if it needs to be delivered into a very acidic environment. Gastric emptying is slowed. So that will also impact, remember what we talked about on our first day with pharmacokinetics. And then intramuscular absorption is faster. Okay, we used that as something that was a little bit slower, but it's irregular. So it's not going to be a sustained release. It's going to have some variability. Distribution, our pediatric patients have greater total body water, which means lower fat content. So if you think about when we talk about a lipophilic, a fat-loving versus a hydrophilic drug, then it could impact the distribution. We have less protein binding. So remember what we talked about with albumin and protein-bound drugs. If there's less protein binding, that means that there's more free drug available, which means that we need to be careful of toxicities, because remember, bound drug is inactive, but free drug is the drug that is actually available to work in the system. Okay, there's an immature blood-brain barrier, so more drugs enter the brain. So that's important when we think about what kind of things we're giving our patients and what medications might actually enter the central nervous system and how would they impact our patients. For metabolism, our liver is still immature. It does not produce all of the microsomal enzymes that we need to metabolize our medications. But older children may have increased metabolism and they may require higher doses. Okay, nobody's going to ask you what dosage would be appropriate, but you need to understand that there are some differences, okay? With excretion, our kidneys are also immature, and so it affects the filtration rate and secretion. And if there is a decreased perfusion rate, then the kidneys may reduce the excretion of those drugs. Okay, pediatric drug dosages may be affected by a thinner skin and more permeable skin. Remember, we have less stomach acid, and so we could have more bacteria in there, but it could also impact medications that need to be in a higher acidity environment. Body temperatures are less well regulated, and dehydration occurs easily. And liver and kidneys are immature, impairing or impacting metabolism and excretion of medications. Okay, general considerations when you're dealing with a pediatric patient. If the caregivers can stay and if they're helpful and if they're appropriate, then they need to be involved. Okay, those are the safe people. Okay, but on the opposite side of that, an adolescent may not want to have their parents around. So you just need to use your judgment. Okay, audience response question. When administering medications to pediatric patients, the nurse understands that the dosage calculations for pediatric patients are different than for adults because pediatric patients, is A true? Do we know anything to indicate that A would be a correct answer? About B, do they have more stomach acid? If they had more stomach acid, then that would make their gastric pH more acidic, and that is not the case. Okay, they have more permeable skin, not less. Remember, if any part of the answer is incorrect, the whole answer is incorrect. So let's eliminate that one. D, do they have immature liver and kidney function? That is a true statement. Now, let's look at the next statement. Resulting in impaired drug metabolism and excretion. So that is true. Okay, so the answer to this question is D, as in dog. Okay, so let's move to older adult patients. So when we talk about older adults, we're talking about the group of patients who are 65 and older. They have a very high use of medications. These patients are often on a lot of medications. And the other term that we use for that is polypharmacy. Okay? We have issues with noncompliance and non-adherence. We talked about that in our introduction day. We need to figure out why they have problems with noncompliance. Okay? They have more chronic illnesses. So our patients are coming into the hospital with an acute problem. So they have a new problem that's affecting them now, but they have all of these other chronic illnesses that they're coming in with that we also have to manage. Okay? As we age, we have sensory and motor deficits, which we have to assess for. Okay? If our patient has vision problems, then we need to be able to make sure that when we send them home, that they can see what they're doing. Okay? Or motor deficits. Do they have the manual dexterity to open up a bottle? Okay? Things like that. So here are some physiologic changes in the elderly patient that I do want you to kind of keep an eye on. We're not going to get too detailed about this in this course, but they do have a decreased cardiac output. So if you have a decreased cardiac output, the amount of blood that leaves the heart with each ejection is less. And remember, we rely on the blood to carry our drug to our target tissues. So that can decrease absorption and the distribution of the drug. Okay? Our GI tract has an increase in pH, which means it's more alkaline, which can alter the absorption of our medications. There's delayed gastric emptying. There's decreased metabolism with the liver and decreased function and glomerular filtration rate, which is going to affect the excretion of the drugs when we're talking about the kidneys. Okay. Factors underlying altered responses in the geriatric population, we've already talked about this. Okay. Secondary to altered pharmacokinetics, secondary to organ system degeneration. That's a fancy way to say that our patients are aging. So nothing's going to work as well as it did when we were younger. Okay. So hepatic enzymes are going to be decreasing. glomerular filtration rate is going to decrease all of those things. Okay, they do have multiple and severe illnesses. They are on that multi-drug therapy, which can impact, those different medications can impact each other. And then there is an issue of poor adherence. So the percentage of oral dose absorbed does not change with age, but the rate of absorption may slow due to reduced GI flow. Gastric acidity is reduced, which may alter the absorption of some drugs. It depends if they need a more acidotic or alkaline environment. Decreased muscle tone and activity is the reason that we have decreased gastric emptying. And the absorptive surface of the GI tract is reduced. They have increased body fat, so we can actually end up with a storage depot for lipid-soluble drugs, which means that the drugs aren't in the plasma where we need them. They have decreased lean body mass. They have decreased total body water, and they have a reduced concentration of serum albumin. So if we have protein-bound drugs, this is going to impact that. So we need to monitor the amount of free drug in the blood. Half-lives may increase related to decreased metabolism. Okay, let's look at the second bullet. Y'all can read these other ones. But accumulation of drugs secondary to decreased renal excretion is the most important cause of adverse drug reactions in older patients. Okay, so we need to keep this in mind. Accumulation of drugs, because the kidneys are not working as well. So now we have more drug in the system, okay? And this can cause problems. I am not going to test you specifically over this list. This list is from your book, and I just wanted you to see and appreciate the numbers of different drugs that can cause complications specific to the older adult patient. But please, please, please do not spend a lot of time memorizing this chart. Okay. Medication administration considerations in the older adults. Obviously, we need to look at their age. We need to look at allergies. We need to do that with any patients. Okay, their dietary habits. Do they have any sensory, visual, hearing, cognitive, and or motor deficits? This is going to affect their compliance and adherence and their ability to self-medicate. What is their financial status, and do they have any limitations? Do they have access to their medications? Can they afford them? Okay. We also need to encourage our patients to keep a list. You know, I talked to you about those medication lists on our first day of class. We need to encourage our patients to do this. They don't always know that this would be a good thing for them. But if we tell them, if we teach them, make a list of the medications, make a list of the providers that you see, make a list of all of these things and carry it with them so that it's accessible if they're seeking treatment. Okay, monitoring lab results. Okay, that could be peaks and troughs of medications like we talked about on our first day of class. This could be liver enzymes or liver studies to look at how well the liver is functioning. This could be a BUN and a creatinine for our kidneys or a creatinine clearance. Okay, all of these things. And that is it. Okay, so for this self-study module, the things that I want you all to be most familiar with is the basic changes that happened on both ends of the spectrum. So take a look at what happens in the kidneys. Take a look at what happens in the liver. Take a look at the changes that happen in the GI tract. Take a look at how each end of the spectrum is going to happen a little bit differently. Okay. Also included in this are some of those medication calculations are fair game. We may ask you something like if the for kids, because we dose medications more in our pediatric populations based on weight. So we may give you a safe range of medications per kilogram, and you might need to actually calculate that out. Okay. So what I wanted to do was give you an example of what kind of question we may see, and I'm in the textbook right now, so you can take a look at this, and I'm on chapter 3. I'm at the end of the chapter, and we are in the area where we've got some practice questions, some NCLEX exam review questions. This is also a good opportunity to make sure that y'all know that these are here, because these are some good questions that will help you evaluate your learning. Okay, Specifically, I want to bring your attention to, it is number 7. And the question says, the nurse is preparing to give an oral dose of acetaminophen to a child who weighs 12 kilograms. The dose is 15 milligrams per kilogram. How many milligrams will the nurse administer for this dose? Down here is your answer. Okay, so you can check yourself. But type questions that are like this may show up on your test. And this is a perfect opportunity for us to test you on both math and the understanding of this information. And we do dose pediatric medications based on weight. So this is an exposure for you to see how this all works and to start practicing on that style of question. Okay, that's it. See y'all later.